Yeah, hello, assalamu alaikum. Good afternoon, everybody. I would like to welcome Dr. Arij Al-Harati, who was graduate from King Saud University Board in Internal Medicine. Before that, she did her medicine in the MAM University, and she is fellowship. She had her fellowship also on rheumatology. She working as a member of Charitable Association for Rheumatic Disease. She joined our department about 4 months ago, and now she will give us this interesting great lecture about rheumatologist view of uveitis. Please, Dr. Arij.
So I'll start by this review, which is Uveitis, published on October 2018 with the name of The Eye's Habit. The aim of this review was to identify associated systemic illnesses and help in management of patients on immune suppression, including the biological therapies, which can be required to treat this kind of cases. A small introduction is that why is the uvea called like that? It's a Latin word that means grape. The Roman anatomists felt that peeling away the outer layer of the eye, which is the cornea and the sclera, will leave a grape-like structures, which is the iris, ciliary body, and choroid. If you look at the prevalence, it's about 1 in 1,000 individuals. And uveitis per se accounts for approximately the same amount of visual morbidity in either macular degeneration and diabetic retinopathy. Uveitis is an infection, and as other infection, it will spread to adjacent locations. This picture will show you just the main types of uveitis, which is anterior, and that defined as inflammation to the iris and or the ciliary body. And I have the intermediate, which is in the vitreous humor, as you can see here in the B diagram. And there is the posterior of the retina and the choroid, and there's the pan, which involves all of it. So, as a rheumatologist, why would I care about the eye much? There's a lot of systemic rheumatic diseases that can involve both joints and uveal tract. The majority of patients with uveitis have an immune mediated process, and this is supported by the observation of the leukocytes in the eye and by the known ability to produce uveitis in lab animals by stimulating immune response. However, most of the therapy for non-infectious uveitis, it depended on the location itself, which is anterior, intermediate, pan, and posterior, rather than the etiology, although there are some notable exceptions and are slowly growing now. So is every uveitis related to rheumatological diseases? Of course not. There's a lot of differential diagnosis, if you notice in this table. But from my side, I'm usually concentrating on ankylosing spondylitis, Bahjet, and juvenile idiopathic arthritis. This is with the pediatric rheumatology, because you see the uveitis in these diseases in high percentages, which is 40 to 80%. Other differentials are there and have to be excluded. So the coexistence of uveitis and arthritis is not well understood yet. So you see both of the eye and the joint share some biochemical similarities as the presence of hyaluronic acid, type 2 collagen, and aggregates. And as I mentioned earlier, we can stimulate these effects in lab animals to see the autoimmune responses. The coexistence suggested a shared pathogenesis, but in mice with aggrecan-induced arthritis, which did not produce interferon gamma, developed more severe uveitis compared to the arthritis. The genetics of the uveitis associated with HLA-B27 also support the genetic process. Others are like interleukin 23 receptors and also interleukin 6 receptor and interleukin 18 receptor 1. As I mentioned, we have to distinguish uveitis related to autoimmune diseases from the mimickers. And it's obviously critical to distinguish infection from any other differential diagnosis we have out there. So some infections like the syphilis and tuberculosis can be variable in terms of their presentation within the eye. I believe that the ophthalmologist can easily diagnose that. Some of more common infection, they will include herpes simplex, herpes zoster, toxoplasmosis, and cytomegalovirus. And cytomegalovirus is more common in immune suppressed patients or cancer patients. Most of these infections cause characteristic changes that can be recognized with a slit lamp examination or with an indirect ophthalmoscopy. We also have the masquerade syndromes and the drug-induced disease. Though they are rare, but you have to put them on your mind. The most common uveitis masquerade is the B-cell lymphoma, which is usually confined to the brain and the eye. Typically occurs bilaterally in patients who are older than the age of 45. And the medications by themselves are not a main cause of uveitis, but they are culprits. And they include TNFs, checkpoint inhibitors, intravenous biphosphonates, and several antibiotics. So, how would you differentiate and which labs to ask for? You see, in Behçet disease, it's basically a clinical diagnosis. It's usually bilateral uveitis and it's recurrent, which is involving the retina and vasculitis. Per labs, we don't have a definitive lab test that can support Behçet disease. Another thing is the HLA-B27. So any patient who comes to you with a sudden onset anterior uveitis that is self-limited and usually resolves within 3 months, but they are reoccurrent, ask for an HLA-B27. It's most probably going to be positive, and it's almost 50%. Other than that, you will consider if the patient is symptomatic to do a sacroiliac joint, sacroiliac MRI. Idiopathic uveitis, as similar to other idiopathic diseases, it's a diagnosis of exclusion. For the juvenile idiopathic arthritis, which labs are you going to ask for? Usually, you're going to ask for an ANA in that patient. If they are having a bilateral insidious chronic, that means it lasting for more than 3 months, anterior uveitis, with a limited number of arthritis. Because per se, ANA is not diagnostic, but it is supportive, and it helps in the prognosis of the disease. Within the other autoimmune diseases, you will consider sarcoidosis, and I'll talk about that later and which labs to ask for. And infectious diseases as syphilis is always put in mind. For the tubular interstitial nephritis with uveitis, if from my side as rheumatology or even from ophthalmology point of view, this differential diagnosis was not considered, you might miss asking for a urine beta 2 microglobulin level, which is sensitive, and even supporting the diagnosis and might be sufficient. A renal biopsy is the definitive diagnosis, but you don't usually ask for it a lot. And as I mentioned, tuberculosis is one of the diseases you have to rule out. And by ruling it out, PPD and the quantiferon levels are not the way. You have to do a chest x-ray to make sure it's not there. And the definitive diagnosis is usually by PCR. I'm going to talk about some of the diseases that actually concerns me as a rheumatologist, and I would like to work with ophthalmology regarding that, which is spondyloarthritis, which is the most common systemic disease and is approximately one half of patients with a sudden onset non-infectious anterior uveitis in Europe and North America are HLA-B27 positive. This was a recent study from the emergency room in Dublin, Ireland, and another from Spain. It involved 798 subjects. It was a collaboration between rheumatologists and ophthalmologists, and they concluded that roughly 80% of patients with a B27 associated acute anterior uveitis had an axial spondyloarthritis based on the assessment of Spondyloarthritis International Society criteria. Sarcoidosis, on the other hand, there was a study from Cleveland Clinic that showed 57% of women older than the age of 61 with an idiopathic uveitis had a normal finding on the chest x-ray, but had a CT and that was evident of sarcoidosis. We recently found a slightly lower yield by performing a CT on patients who were older than 40 years old with an idiopathic uveitis. In addition, it was noted that 21% of those discovered to have sarcoidosis on the CT had also sarcoidosis associated ventricular tachycardia. A study from Japan reached a similar conclusion about the uveitis and the cardiac sarcoidosis. Going through the therapy for uveitis and as other immune related diseases, you're going to start by steroids. The anterior uveitis initially is treated by topical corticosteroids, and I know that we usually give patients with spondyloarthropathy um, steroid eye drops to help them when they start to have these symptoms. Although these frequently are effective, their penetration to the posterior lens is limited except for one formulation, which is the difluprednate, and it has a greater ability to penetrate posterior to the lens, but sadly, it has greater side effects. So the complication of topical corticosteroids are usually cataractogenesis and elevated intraocular pressure. Local injection of steroids, like in the trimecanolone, can be useful. However, it is inconvenient and the side effects are even higher. Cataract, glaucoma, liptosis, and in rare cases, retinal detachment. It is injected directly to the vitreous humor where it has the highest benefit and increased risk of intraocular infection or a hemorrhage as well. Oral steroid is another way to treat, but as you all know, the complications with oral steroids are high. Hypertension, diabetes, and osteoporosis is there. So, what are you going to do? Are you going to keep your patients on steroid? Of course not. You're going to start on using steroid sparing medications, including the antimetabolites that are the MMFs, methotrexate, and azathioprine. There was a National Institutes of the Health Response trial, which is the MUST trial, for patients with non-infectious intermediate posterior uveitis or even panuveitis, recently showed there is a superior efficacy of these medications compared to sustained release steroids to the vitreous humor of the eye. This study was concluded after 7 years with the findings of visual acuity testing. Another medication, which is adalimumab, is indicated for patients who previously are treated with oral steroids and failed, as well for patients who have failed the treatment with another immune suppressing medication as methotrexate or MMF. The response of Behçet disease, and this is a special condition, to adalimumab and infliximab, actually warrant the use of these medications without using a trial of other antimetabolites. If we're gonna look at the juvenile idiopathic arthritis anterior uveitis, it is rare to prescribe biological agents there. And since most of the patients are having the anterior uveitis, they are usually controlled with a topical medication alone. The Sakamura study tested the efficacy of adalimumab for patients with GIA who have uveitis active despite the use of methotrexate or topical corticosteroids. And topical corticosteroids. The trial was held early because there was a high evidence of benefit from adalimumab against these medications. Another randomized controlled trial used a different outcome measure, and which is the quantification of protein in the anterior chamber. It also concluded that adalimumab was useful for the chronic anterior uveitis associated with juvenile idiopathic arthritis. What do we think about, or what do we think is going to happen in the future? There are some studies currently ongoing. They are considering the use of JAK inhibitors as flecatinib for induction of similar indications similar to that supporting the use of adalimumab. There is many emerging biologics, but still studies are needed. The limitations for uveitis, though it is increasingly targeted therapeutic trials, and with a search of the clinical trials government website, till February 2018, we only identified 7 current or prior randomized controlled trials involved patients with uveitis. If we tried the other way around and we looked with rheumatoid arthritis, we only had 54 trials available. Therapies delivered locally to the eye might become the treatment of choice for ocular inflammation. And the gene therapy, which is approved in the US by the USFD, is successful. You see, the injected gene enters to confined space with minimal worries about expression in other tissues. This successfulness was related that the therapy for ocular inflammation needed to target only 2 locations, unlike other autoimmune where it needed even more. We think that in the decades ahead, 1 or more locally delivered inhibitors of inflammation might become the standard treatment. In my conclusion, it is recognized the challenges in attempting to familiarize oneself with a group of diseases that actually cannot fully assess by using the tools in a certain specialty, or at least in rheumatological clinics. Moreover, I think it is better if we, and it's actually time helpful that we establish multidisciplinary clinics where we can combine between rheumatologists and ophthalmology to see regarding these certain diseases and discuss the need for immune suppression and what other options do we have. Thank you so much for listening, and this was my talk, and I accept any questions.
Thank you very much, Dr. Arish, for this interesting talk and update. We can open the for discussion, the meeting for discussion. Anybody wants to ask any question, please put on your mic and you can ask.
Dr. Rashid, good afternoon.
Yes, Dr. Hassan, please, good afternoon.
Yeah, my question to Dr. Arish actually regarding the diagnosis or excluding tuberculosis, it should be by, as she mentioned, chest X-ray and PCR, and she excluded that quantiferon and PPD tests are not that useful. But my question is regarding PCR from where? Is it from sputum, gastric lavage, or what? Please.
Thank you, Doctor, for that question. Regarding the TB, it is not recommended to screen patients with for TB, in the US, unless you are born outside or in an endemic area like Saudi Arabia. So depending on the patient's situation and depending on the eye findings from the ophthalmologist, you can proceed with doing the chest X-ray and the PCR, usually from the eye itself. You can take a sample from the vitreous humor, as much as I've read, and that's it, basically. Or even you can start a trial of a medication, okay, along with the immune suppression medication.
Okay, thank you. That's good. Thank you very much.
Okay, Victor.
I have a comment. This is Dr. Sulaiman. Thank you, Dr. Arish, for the lecture. Can you hear me?
Yes, we can hear you clearly, Dr. Sulaiman. Please.
So the yield of PCR and TB from the vitreous is low. So we don't routinely do it. I have a question regarding your approach to Behçet's disease in terms of management and the rheumatology literature. Do you prefer to go with biologics as first line, or you still go with the conventional immune suppression prior to switching to biologic treatment?
Thank you, Dr. Salman, for the question. Sulaiman, sorry. Regarding Behçet disease, we usually depend on the presentation. You see, with the cutaneous Behçet, you have certain medications, and usually it's azathioprine and colchicine. But if it reaches the eye and it involves the eye, we usually think about infliximab and adalimumab. Even in infliximab, we might consider other medications as glomimumab, if those two failed, actually.
So what if it does not involve the eye? Let's say like neurobehçets or with gastrointestinal manifestations.
You consider oral, actually. You're going to consider azathioprine, Cellcept, and so on.
Okay. Thanks.
Okay. Any more questions?
Yes, Dr. Arij, thanks again for this really interesting talk. My question regarding the anti-metabolite, there is a limit how many times you can use it, or there is no limit, you can use it as far as it's needed? I mean, how many times? 10, 15, 20?
Sorry, Dr. Zaitouni, which anti-metabolite?
Like infliximab.
For infliximab. Usually,
yes, go ahead.
We usually, in rheumatological disease, we will give a cut down for the medication when the patient's condition is stable. There is no limit actually to say as a duration of stability, but usually you consider that from 6 months and to 2 years, depending on the medication before you say it failed and you think about switching it. For a failure of biological treatment, you will say that after using the medication in adequate dose, 3 to 6 months, actually, before you say this medication failed and you will consider switching.
And if this medication is successful, you continue up to 2 years, then you have to stop it, or you can continue forever?
Actually, you don't stop it promptly. You space it. Some of them try to decrease the dose or increase the decrease the frequency of the need.
Okay.
So another question about biologics. So now, what is your maximum dose in infliximab treatment, and how do you play with the dose of adalimumab? So do you reduce the duration, make it like weekly, or you just increase the dose of Humira? How do you address patients who are not responding in the initial phase of treatment?
Usually in the initial phase of treatment, you're not going to depend on the biological treatments alone. You're going to also support it with steroids, okay? But once the patient reaches their stable condition, we would say for a certain amount of time, the first medication you're going to take out is the steroid. You will decrease the doses, of course, slowly, and after that, you will consider the biologics. How to stop it or how to reduce the medication? You're gonna either increase, as I mentioned, for adalimumab, for example, you're taking it once every 2 weeks. So after that, if the patient is stable for some time, you're gonna give it once every 3 weeks.
And it is the opposite if it is not working.
If it's not working, as I mentioned, you're gonna try others.
Yeah, so what is your maximum dose of Humira and your maximum dose of infliximab? That you would say, well, this drug has failed, I have to switch.
I would actually consider that with the maximum doses of both, okay? For each one, I mean. As I mentioned, up to 6 months. before I say that. Or at least
Okay.
6 doses of the medication in case of the infliximab, because it's usually every 2 months.
Okay. So like infliximab, you go up to 10 milligrams per kg?
Depending on the patient's condition. I didn't actually give that maximum dose of 10. My maximum was usually 8.
And Humira, how do you change the dosage?
The Humira recommended dose is 40 milligrams every 2 weeks. And
Yes.
if I did it for the patient for up to 4 months and it didn't work, I will actually switch it.
So you don't reduce the duration, make it weekly or increase it to 80 milligrams?
No.
There is some literature suggesting maybe there may be benefit of doing so in ophthalmology. I don't know about rheumatology literature.
From ophthalmology, I really cannot say, but from rheumatological point of view, 40 for 2 weeks. If it doesn't work, we'll consider switching.
Okay. Thank you.
Thank you, Dr.
Well, it seems there is no more question. Many thanks again, Dr. Arij, and good luck.
Thank you all. يعطيكم العافية.
Thank you.